Hello, friends. I'm back after a gap of 3-4 days. Yesterday, I was speaking at North India Foxy Forum. I was speaking on a kind of topic that is fibroids. So I thought today, let me take an obstetric topic. And this is a very important issue of the 4 to 5 common cases that we meet in obstetrics. One of them is preterm labor. And we all know that preterm labor is sort of having a direct relationship with infections. So I thought there are lots of now evidence and lots of thoughts coming up in this area. It would be useful to both practicing obstetricians to know how to actually do preventive treatment as well as the curative treatment for the infections that would lead to preterm labor. It would be a nice theory topic for the postgraduates to write an answer in the exams. Preterm labor ending in preterm birth is a leading cause of infant morbidity and mortality globally. We all know that. That's why the pathogenic process leading to preterm birth are major targets for obstetric research. Lots and lots of research is going on in this direction. 4 major pathogenic processes that are blamed for preterm labor are: number 1, premature activation of fetal hypothalamic pituitary adrenal axis in response to maternal and or fetal stress. I have dealt in detail about this in the initiation of labor. Suffice to just recall quickly that whenever there is stress for the fetus in any form, there will be production of cortisol that would encourage the production of CRH, and that CRH would in turn increase the substrates in the fetal adrenal, which are necessary for aromatization in the fetal placenta unit to form the estrogen. And estrogen is the dominating hormone towards the end of pregnancy, which will produce encouraged to produce the prostaglandins, which in turn will actually sensitize the myometrial cells to have better response to oxytocin. CRH also directly makes the muscles excitable to oxytocin. So that whole feto-maternal placental unit acting together little prematurely is one of the reasons. The second one is exaggerated inflammatory response or infection and or altered genital microbiome. This is one of the important causes of preterm labor, that is exaggerated inflammatory response. Yesterday, I was telling you during my talk that most of the diseases have their origin in the inflammatory response by the body, the differential response. Here it is an exaggerated response. The third one is decidual hemorrhage, which in the 3rd trimester would be like a placental abruption, which would separate the placenta and the membranes from the decidua. So there will be production of prostaglandins and preterm labor. And finally, pathologic uterine distension. So distension itself will make the uterus contract according to Stirling's law. But today I'm not going to explain much about the other things, except I would be concentrating on exaggerated inflammatory response to infection and or altered genital microbiome. So let us see what it is. Epidemiologic studies using lab and clinical data show an association between spontaneous, SPTL means spontaneous preterm labor, and the presence of systemic and genitourinary tract pathogens. That means infection not only in the genitourinary tract, infection anywhere else in the body also is associated with preterm labor because of the pro-inflammatory factors that are released, which I am going to talk in detail a little later, as well as altered microbiome. So you can see a whole lot of studies starting from 2019, 2009, and as low as 2001, where Cochrane data based systematic review also suggested this. So retrospective study of nearly 2 lakh deliveries found that 2.5% of patients had asymptomatic bacteriuria. So this is the reason why we advise nowadays a routine urine culture at least once in a pregnancy, preferably in the second trimester, because that's the time if you can treat it, then you can avoid preterm labor. We have adopted this more or less in Manipal, which was independently associated with spontaneous preterm labor. And the diagnosis and treatment of ASB appears to reduce the risk of spontaneous preterm labor. So all the three sentences are pointing that we have to identify, diagnose asymptomatic bacteriuria, and the only way to diagnose is by doing a routine urine culture because they are asymptomatic, obviously, and all of you know the definition of it. Anything more than 10 to the power of 5 colony count is bacteriuria, which is significant, requires treatment, else they may land up in preterm labor. Chorioamnionitis. I have taken a detailed class on triple I. Triple I means intra-amniotic infection or inflammation. Today, I'm not going to again deal with the criteria, etc. But suffice to say, both clinical and subclinical chorioamnionitis. Please refer to my lecture. What is the meaning of clinical and what's the meaning of subclinical, and all those things are much more common in preterm rather than in term deliveries. So it is very important. As a couple of slides ago, I told you, whether there is infection in the genitourinary region, whether there is infection systematically, it will definitely affect. There will be exaggerated inflammatory response and landing up in preterm labor, and may account for 50% of spontaneous preterm labor before 30 weeks of gestation. So that is the reason, if you have got so many reasons for preterm labor, 50% of them is due to infection, and in that you can say triple I is one of the important reasons. So as I said, I will not go into the criteria of triple I, but suffice to say the diagnosis for treating triple I, ACOG suggests that patients with isolated fever that is equal to or more than 39 degrees centigrade without another clear source should be managed as having suspected intra-amniotic infection. IAI means intra-amniotic infection. It is the new name is triple I, as they are at high risk of an adverse clinical outcome. So you don't have to wait for other criteria like the increased TC, total count, amniotic fluid assessment, and WBCs in amniotic fluid, and all those criteria are not required. Just the temperature more than 39 degrees centigrade is enough to start treating as per ACOG. Similarly, National Institute of Child Health and Human Development, they also said their criteria de-emphasize the use of maternal tachycardia. So just the temperature is good enough to treat, and fundal tenderness and for clinical diagnosis. Let us now go one by one, the organism culprits. Preterm labor and lactobacillus. All of us know that lactobacillus are also common cells of the vaginal flora. It is the predominant flora of microbial community in the normal pregnancy. The prevalence of lactobacillus poor vaginal community state type 4 is inversely correlated with the gestational age at delivery. So we all know these lactobacillus are protective in nature. So if their colony reduces, the infection will increase. And it's been found that their colony count or state is inversely correlated with the gestational age at delivery. So that means the colony count, as the colony count decreases, gestational age also is going to decrease because they are going to land up in preterm labor. The risk of spontaneous preterm labor is more pronounced for women with CST4 and elevated Gardnerella or ureaplasma. These are pathogenic microorganisms. Lactobacillus is almost like, I can say, physiologic or common cells in the vagina, whereas Gardnerella and ureaplasma are not. So that is the thing. However, treatment of bacterial vaginosis does not reduce spontaneous preterm labor rates in low-risk patients. That means In high-risk patients, yes, because the treating infection becomes very important. But in low-risk patients, the treatment is not really going to help us because there may be other infections or other problems which we have to tackle. Bacterial taxa and preterm labor. A nested case control study of cervicovaginal microbiota among 107 patients with spontaneous preterm birth and 432 women with term deliveries found that Mobilincus curtisi and mulieris to be only bacterial taxa significantly associated with increased risk of spontaneous preterm labor among all participants. So this is the organism they have isolated. That is the reason why maybe that the previous slide said in low-risk patients just treating Gardnerella or usual vaginosis, bacterial vaginosis may not help because these are the organisms that are maybe culprits. However, newer techniques to diagnose infection are very important. What is the meaning of this? See, what happens is sometimes when you just look at under the microscope, or even if you send for culture sensitivity of the vaginal secretions or even amniotic fluid, you may not isolate any colonies. They may not grow anything. That is why, but there is infection. Infection in the sense, infection good enough or bad enough to give rise to inflammation, which is the cause of preterm labor. So they have come up with newer techniques which are different from culture and sensitivity. Metagenomic techniques, including surveillance of 16S RNA gene. They have increased understanding of the spectrum of cultivated and uncultivated human microbial agents. That is what I was trying to tell you. Some organisms may not grow in the culture media, and you can't say that's why there is no infection. So you have to have a newer technique. For PGs, please note that metagenomic techniques, wherein they will survey for the 16S RNA gene. And that, if it is present, then there will be, they will report it as infection present, which are involved in the pathogenesis of spontaneous preterm labor. What is this metagenomic techniques? I'm not going to explain that. Obviously, it is not my concern. As long as microbiologists know how to do it, I'm very happy to simply believe their report. Using these, several groups of investigators reported that in spontaneous preterm labor, secondary to infection, approximately 2/3 of the amniotic fluid bacteria detected by culture-independent methods were not isolated in cultures. So that is what I have been trying to tell you. Some microorganisms are simply not growing in any culture. So you cannot say that the infection is not there. If you use metagenomic techniques, you can still identify them. These included are Fusobacterium nucleatum. I can't remember these names, but I've put it here. You can remember it. Leptotrachea and Burgella. I can't even pronounce them maybe. Peptostreptococcus, not very difficult. Bacteroids and species of other Clostridiales. So these are the organisms which may not grow, and the culture report may come as negative. It is misleading. That's why you need a different newer technique called metagenomic technique, which will survey for the 16S RNA. So integrative human microbiome, what is that? Let us see what it is. This project, actually, they used 12,000 samples from 45 preterm and 90 preterm birth controls. Longitudinal analysis of metagenomic, they used metagenomic method as I was talking in the previous slide, and metatranscriptomic cytokine profiles and 16S RNA. By now you are familiar with the 16S rRNA identified. Lower vaginal levels of Lactobacillus was seen in this project, and higher levels of bacterial vaginosis associated bacterium BVAB1 and TM7, and Snathia amni, a group of Prevotella species, and 9 additional taxa as harbingers of spontaneous preterm labor. In other words, if you can't remember these names in an exam, if you remember one or two, Snehita is here, Snehatia, but you can simply say there are microorganisms which are not growing in the culture media, but they can be identified this by newer technique. So this technique you should at least remember, metagenomic technique, wherein they identify 16S RNAs. What is the risk of preterm labor with selected infections? So here comes the table, which will give us an idea. Bacterial vaginosis before 16 weeks, the odds ratio is 7.55 times, isn't it? That's a very high. Bacterial vaginosis is the highest. Neisseria gonorrhea, 5.31 odds ratio. And asymptomatic bacteriuria is 2.08. Chlamydia trachomatis at 24 weeks, also 2.2. At 28 weeks, it's of course not very high. Trichomona vaginalis 1.3. Anything more than 1 is significant, right? Ureaplasma urolithecum is just 1. Okay, so these are the organisms that have the risk for spontaneous preterm labor. Now, having understood a little bit about the microorganisms that are implicated in the preterm labor and the methods to diagnose them other than culture, let us look at the pathophysiology of this. Bacterial degradation of the membranes is blamed as one of the important pathophysiology, and as you can see here, it's been proven in 1985, so long ago. So it is very, very clear now, and nobody has challenged this after that. Pseudomonas, Staphylococcus, Streptococcus, bacteroides, and Enterobacter produce proteases that will break down the proteins, collagenases that will break down the collagens, and elastases that will break down the elastic fibers as well, that can degrade the fetal membrane. So whatever resilience the fetal membranes have got, that can be simply broken by these trimurtis. What are the trimurtis? Proteases, collagenases, elastases. So there will be rupture of membranes, leading to PPROM with subsequent spontaneous or indicated preterm labor. See, if PPROM occurs, spontaneously she may get into labor because of the release of prostaglandins and all those things. Secondly, there can be infection. Thirdly, you may be forced to deliver them. That's why the meaning of spontaneous or indicated preterm labor will eventually ensue. So it is basically bacterial degradation of membranes because of proteases, collagenases, and elastases. So bacteria produce phospholipidase, lipase A2, which leads to prostaglandin synthesis. So they not only break down the the membranes, but they also lead to production of prostaglandins by producing this phospholipase enzymes A2. Endotoxin, they produce endotoxin. That is why infection anywhere in the body, it need not be genitourinary, endotoxins can move around in the body. The substances that stimulate uterine contractions and cause preterm labor. That is the reason infection anywhere in the body, which will give rise to these enzymes or endotoxins, you can have preterm labor. Bacterial induction of inflammatory response, let us see, leading to uterotonic effects. Bacterial ligands bind to toll-like receptors. They are like tolls, toll gates, what we see in the highways. They are called TLRs, expressed on decidual, amnion, chorion, cervical, placental, and local leukocyte cell membranes. So what more you want? It will bind to all the cells, basically. Decidual cells, amnions, chorion, cervical, placental, local leukocyte cell membranes. So this induces the transcription factor, which is called NF-kappa B, which then triggers a material and or fetal inflammatory response in susceptible individuals that is linked to spontaneous preterm labor. See how they do that. So when they go and bind the bacterial ligands, when they go and bind the toll-like receptors on these particular cells, they induce a transcription factor, which is called NF-kappa B, which will trigger inflammatory response, which is in susceptible individuals that is linked to spontaneous preterm labor. So TLR-mediated response, that is toll-like receptors, characterized by the presence of so many things. What are they? Activated neutrophils and macrophages, various pro-inflammatory mediators, interleukins 1, 6, and 8, notorious ones, tumor necrosis factor, TNF. See, the present-day students are very well versed with all these things. During my time, to be frank, we never knew about so much about interleukins, tumor necrosis factors, and things like that. But the current generation of students, they are very well versed with this. Then granulocyte colony stimulating factor, GCSF, infertility specialists, we know all of this. Colony stimulating factors, CSF2, and matrix metalloproteinases, MMPs. So you have to remember this NF kappa, what I was talking about, B, and MMPs, which is going to come up many times in future slides. So all these things are, released in the TLR-mediated response, and that's why, they will create an exaggerated response, which will lead to spontaneous preterm labor. So key initial mediators of this response are interleukin 1 beta and tumor necrosis factor. They enhance prostaglandin production by inducing COX-2 expression in the amnion and decidua. Again, I request all you to recall or revisit my lecture on the pain mechanisms in endometriosis. COX-2, prostaglandin, estrogen have a vicious circle. They will create this kind of a problem. They are encouraging each other, and that is the reason there will be preterm sort of a labor, okay? And that's the reason probably in endometriosis there is very, very crampy type of pain. They inhibit the PG metabolizing enzyme, 15-PGDH in chorion, so prostaglandins are not destroyed. Moreover, that interleukin 1 beta and the tumor necrosis factor directly enhance the expression of various matrix metalloproteinases, MMPs. I told you, MMPs, you should remember, they will keep coming in the amnion, chorion, decidua, and cervix to degrade the extracellular matrix of the fetal membranes and cervix. So what happens? Cervix gets ripened and the fetal membranes also are destroyed. Prostaglandins are produced. What more you want? This is a perfect recipe for labor. Now, a little bit about immunohistochemistry. Staining of placentas with immunohistochemistry with chorioamnionitis associated spontaneous preterm birth shows significantly lower progesterone levels in decidual cells. This again and again proving, see, since last 2 weeks, I've been talking about initiation of labor, induction of labor, and I don't know how many times I have repeated this. Progesterones have to go down, estrogen has to come up, and estrogen is the one which is going to stimulate the prostaglandin production. It is going to stimulate the oxytocin receptors. It will make the uterine muscles excitable. And all that you need is a lowering of the progesterone level. So this can be identified if you used immunohistochemistry. Treatment of cultured term decidual cells, okay, with interleukin 1 beta, decreased PR expression. So if you take this term, see how beautifully they do the research and prove their point. That's what hats off to these people. they find an association and they prove it by doing something. See, they thought that there is lowering of the PR levels, but then they wanted to prove it that there is an association between that and the interleukins. So what they did, they treated these decidual cells, the term culture, they treated them with the interleukin-1 beta and found that there is a decreased PR expression, both PRB and A isoforms, as well as PR mRNA levels. So this is so beautiful. This reduction in PR expression may account for studies showing no benefit of progesterone supplementation. So when the whole system is working against you, it's like, again, yesterday I used the same word somewhere, Ravanan Hottege Kasina Majjige. That means, for an ocean, if you pour 1 bucket of water, it's not going to help. Few tablets, few injections of progesterone is not going to help when the whole system is working against it in favor of labor. So elevated pro-inflammatory mediators have been demonstrated in amniotic fluid of women with preterm labor with intact membranes. So they are going to rupture the membranes soon. So when there is increased pro-inflammatory mediators. These levels correlated well with the positive results from the culture of amniotic fluid and fetal membranes. So review of 17 studies involving 6,270 asymptomatic women elevated cervicovaginal and amniotic fluid interleukin 6, 1, 6, and 8 are notorious, I told you. Levels at mid-gestation predicted spontaneous preterm birth. So this may be one of the thesis topics for students. So you try to find out the elevated cervicovaginal and amniotic fluid. So amniotic fluid may be difficult, you have to do amniocentesis, but cervicovaginal fluid, if you can isolate interleukin 6 levels and then follow them up, see whether they will have preterm labor. It's a fantastic thesis project. Patients with intra-amniotic inflammation destined to deliver preterm appear to present unique amniotic fluid, vaginal secretion, and serum proteomic profiles. So this again proving that there are inflammatory mediators that are working 24/7 to make sure that she gets into labor, rather preterm labor. Now, it's very interesting, periodontal disease. One of our PGs, I think Dr. Suvriti, if you are listening to this lecture, you can raise your hand and say yes. I think Dr. Suvriti did a thesis on periodontal disease and preterm labor. It was very interesting thesis and interesting findings she had. 2 systematic reviews have reported an association between periodontal disease and adverse pregnancy outcomes such as spontaneous preterm labor. That's why she did this thesis. But unfortunately, it did not provide conclusive evidence that pregnancy complications, including spontaneous preterm labor, resulted from periodontal disease. There was an association, all right, but we could not really blame it squarely on periodontal disease as such. But nothing prevents us from learning more about it. That's why I'm proceeding with this another couple of slides. Oral bacteria that have been associated with both periodontal disease and preterm labor include all these things. I don't want to spell them and get into trouble. So whatever it is, you take a screenshot of that. So the theories behind, this periodontal disease is that periodontal flora may seed the fetoplacental unit and cause local inflammation. From here, the infection goes through hematogenous route and it will be, sowed on that placental unit, and that will cause local inflammation. Inflammatory mediators of periodontal origin may cause systematic inflammation. That is also another thing. And periodontal disease is a marker of individuals who have a genetic predisposition towards exaggerated local or systemic inflammatory response to a given stimulus. That's the thing. All of us get the same stimulus, but all of us not will react in the same way. We must have a genetic predisposition. Yesterday also I was studying the same thing with respect to fibroids. All the ladies will have estrogen, progesterone, menstruation, everything. But some ladies, the menstruation will act like an injury and the consequent inflammatory process is exaggerated in those women, and the levels of estrogen will have an exaggerated effect on those particular cells which are genetically determined to behave in an abnormal way, in the sense to multiply more and grow. So that's what is the beauty of this life. All of us have got 2 eyes and 2 ears and 1 nose and 1 mouth, but all of us do not look the same. We all look differently, even in physiology. So how can we all be same in pathology? Periodontal disease also may cause exaggerated local or systemic inflammatory response that lead to periodontal disease in preterm. Such individuals may also hyper-respond to vaginal bacteria with enhanced production of cytokines that lead to PTL or PRN. So this slide explains what I meant earlier. Periodontal disease is associated with, let's say, preterm labor, but there is no direct connection as such. But these ladies generally have a hyper response to any infection anywhere, and if they have exaggerated response at the vaginal bacteria, that is the reason probably they will have preterm labor. Thus, periodontal disease and preterm labor can be epidemiologically linked but not causally related, right? So I hope you understand. Epidemiologically related, yes, but they may not have a direct connection. The connection may be indirectly, because these ladies have general hyperresponse to any infection, whether it is periodontal infection or vaginal infection. But vaginal infection may be the reason, but you will see the association that those who had preterm labor also had periodontal infection. But periodontal infection may not have caused preterm labor. I hope I am very clear. So now let us look at this flow chart. Chorioamnionitis, there is increased interleukin beta 1 beta binds receptors, and NF kappa B. Remember, I told you about NF kappa B. These are the transcripts, and that will stimulate COX-2. COX-2 and PGs are, PG means, I mean, prostaglandins are close friends. So they increase PGF2 alpha, and on the other side, ERK1 and 2 MAP kinase, they will have the effect in form of decreased progesterone levels, which is a perfect recipe, as I said. So there is decreased PR activity, there is increased PGF2 alpha, increased MMP. What is MMP? Matrix metalloproteases. So on the other side, there is increased MMP3 also. On the whole, there will be rupturing of the membrane, cervical ripening, increased contractions, membrane rupture, and cervical ripening happens. So leading to preterm birth. This is number 2. What is number 1? The stress increased in the fetus. What I told you, number 1, 2, 3, 4 at the time in the first slide. So there is increased glucocorticoid receptor activity, FKBPS51, which will lead to the same pathway, decreased progesterone and rest of it. Abruption, that is separation of the membranes, increased thrombin binding PRs, and the same thing again through COX-2, as well as decreased progesterone, decreased PR activity, increased prostaglandin, finally leading to the same pathway. So you can take a screenshot of this if you want. Finally, I'll try to wind up in another 6 minutes, the interventions. No point in just talking about the infections, but how to treat them. Urine culture is a must. As I told you, make a habit of doing routine urine culture. First trimester urine culture should be performed on all pregnant women. We do it in the second trimester, unless she's symptomatic in the first trimester. Regular antenatal screening is recommended for women at high risk for asymptomatic bacteriuria. Example, women with sickle cell trait, recurrent UTI, diabetes mellitus, underlying renal disease. Women with asymptomatic bacteriuria should be treated, even though they don't have symptoms, with antibiotics to reduce the risk of developing pyelonephritis, the immediate one, as well as spontaneous preterm labor, the later effect. Genital tract infections and colonization in general. Some trials reported reduction in spontaneous preterm labor with routine screening and treatment for infection in second trimester, but we don't do this for genital infections, while others have reported no benefit. That's the reason. The discordant findings may be due to confounding by recolonization reinfection is one thing after therapy. Intercurrent use of non-protocol type of antibiotics, you have used half-hearted antibiotics. Failure to culture fastidious bacteria leading to misclassification of women as non-infected. That's where you need those genetic type of studies. Role of empiric antibiotic therapy. Many people believe in giving weekly, monthly antibiotics for the fear of infections. Empiric antibiotic therapy does not reduce spontaneous preterm labor as per this study. A meta-analysis of 17 RCTs also showed that there was no significant association between antibiotic treatment and reduction of spontaneous preterm labor, regardless of criteria used to assess risk, the antimicrobial drug administered, or gestational age at the time of treatment. So there is no point in simply giving antibiotics, better to avoid actually. Role of empiric antibiotic, what does Cochrane review says in 2015? Their meta-analysis also found that intervention did not significantly reduce the risk of spontaneous preterm labor. Very rarely Cochrane review comes up with very strong statements like that. Or PPROM, both, it did not reduce. What about bacterial vaginosis, ureaplasma erythritecum, and the GBS? Prospective control studies and meta-analysis have reported either a modest or no effect on antibiotic treatment on prolonging gestation in asymptomatic women who screened positive for bacterial vaginosis, ureaplasma erythritecum, or GBS if they are asymptomatic. Although these studies are undoubtedly confounded by recolonization, reinfection after therapy, and intercurrent use of non-protocol antibiotics. This is standard statement. What about trichomonas? It is again the infection if in HIV negative women is not recommended during pregnancy because there is no convincing evidence that it reduces the risk of spontaneous preterm labor. Chlamydia, gonorrhea, syphilis. There is no evidence that treatment of chlamydia, gonorrhea, or syphilis prolongs gestation. The only control trial that evaluated the effect of treatment of chlamydia on gestational duration did not show a reduction in spontaneous labor. So there is no point in simply treating all these people. However, screening for and treatment of these infections is recommended to prevent other maternal and neonatal sequelae. Malaria in places where it is rampant. Malaria is associated with preterm labor, low birth weight, and other maternal neonatal morbidities. So prevention of malaria infection and treatment of established malaria infection can reduce the risk of spontaneous preterm labor. What about periodontal disease? I talked so much about it, so I should tell whether to treat it or not. Of course, although the treatment of periodontal disease contributes to oral health, there is no strong evidence that treatment of periodontal disease improves pregnancy outcome because in the first place, they were not directly correlated. They had only association, epidemiological type of association. Suppose this lady has another infection, and if you have neglected that or not treated that, then just treating periodontal disease is not going to help. Of course, it will improve the oral health. Thank you very much for your patient listening. So I hope I have made some justice for the topic and given you something to write in the exams. Thank you very much. Tomorrow is actually KCOG program. Dr. Geeta Arjun is going to talk on a very, very interesting topic. Don't miss it. So there is no class tomorrow.